Hello, and thank you for that introduction, Dr. Hicks, and thank you for the opportunity to present today. So the treatment of chronic venous disease has shifted towards a greater prevalence of the use of endovenous thermal ablation versus traditional surgical methods due to the better socioeconomic outcomes, minimally invasive nature, and the ability to perform the procedure in an outpatient setting. The benefits of treating patients with more severe venous disease have been well established. However, the decision to initiate endovenous treatment in patients with more mild disease is less clear. This decision becomes more difficult when considering obese populations, as obesity has been shown to be a risk factor for increasing disease severity, and obese patients consistently present with higher CEAP scores, higher VCSS scores, and lower quality of life scores compared to non-obese patients. So the current research on mild venous disease, and particularly obesity's effect on treatment in these patients, is lacking. Additionally, the most recent SVS guidelines on venous disease from 2011 make no recommendation concerning obesity's effect on treatment in these patients. So our objective was to analyze the impact of obesity on endovenous thermal ablation outcomes in patients with milder disease, with the hypothesis that obesity will reduce improvement. So using the varicose vein registry, we retrospectively analyzed 10,893 limbs with a CEAP score of 2 or 3, undergoing radiofrequency or laser endovenous thermal ablation. Patients were excluded based on missing follow-up data, underweight BMI, or initial follow-up past 3 months. So in order to assess patients clinically, we analyzed the change in CEAP scores and VCSS scores from pre-procedure to initial follow-up. And to assess patients symptomatically, we analyzed the change in patient-reported outcomes, which are all based on a scale of 1 to 5, 5 being the worst, and those are listed here. So it was decided to analyze the change in scores versus the scores themselves to account for pre-procedural differences between groups. So we did this by analyzing our outcomes univariately first between obese and non-obese patients based on a BMI of 30. And then to confirm our findings, we used multivariate regressions. And to keep these regressions as simple as possible, we used multivariate logistic regressions analyzing what we called post-procedural improvement as a binomial outcome that we created for each dependent variable of interest. So in other words, we created new variables for CEAP score, VCSS score, and individual patient-reported outcomes that measured whether or not there was a beneficial decrease in these scores from pre-procedure to initial follow-up for that outcome. We then ran the same multivariate logistic regressions using these improvement variables, which were run with obesity defined by the HWO classifications to analyze if increasing levels of obesity would impact outcomes further. So this is the demographics between groups, and as you can see, all the measured demographic data was significant between groups with the exception of race, and these were the variables that we later used in our multivariate regressions. It's also important to note, as shown in this graph here, that obese patients started with higher average scores on every clinical and symptomatic outcome, with the exception of perceived limb appearance, hence the need to analyze the changes of these scores versus the scores themselves. So this chart shows the average change in clinical CEAP scores and VCSS scores between cohorts, as well as the odds ratios for post-procedural improvement of CEAP scores on the right. So it's shown by the negative values for CEAP and both VCSS that both groups demonstrate average reductions in these categories, confirming we still see clinical improvement in patients with mild venous disease following treatment. However, obese patients show significantly less improvement than non-obese patients, as demonstrated by the significant difference in average delta CEAP scores. So here we show the average change in each patient-reported outcome between cohorts on the left and pre-procedural improvement for each significant variable on the right. And you can see again, both groups show significant reductions in all patient-reported outcomes indicated by the negative changes, demonstrating patients with mild disease also improve symptomatically in addition to clinically. Interestingly, obese patients were shown to have significantly greater improvement in their reported outcomes than their non-obese counterparts. Finally, this graph shows the odds ratios of post-procedural improvement for each outcome with obesity based on the HWO classification, and each group of bars here shows increasing obesity levels from left to right. And as demonstrated by the downward trend of odds ratios for the improvement of clinical CEAP scores, we see that increasing obesity negatively impacts clinical improvement. However, as demonstrated by the general upward trend of the remaining variables, we see that increasing obesity levels positively impact our improvement in patient-reported outcomes. So overall, we continue to see significant improvement both clinically and symptomatically in patients with mild venous disease following endovenous thermal ablation, regardless of obesity status. And while obesity negatively impacts clinical improvement in patients, we see larger reductions in their perceived symptoms following treatment, with higher obesity classes associated with the best improvement in symptoms. For this reason, we believe obesity should not play a significant role in the decision to treat patients with endovenous thermal ablation in mild venous disease. Thank you, and I can answer any questions.
This paper is open to questions. Let's start one. Can you describe to people sort of when these scores are captured, like in relation to the procedure?
Yeah, so from the VQI, it's a reported score on a ordinal scale of 1 to 5. 1 being whether you experience these symptoms never, or 5 being you experience these symptoms all the time, every single day.
But what about in the time course related to when surgery happens?
Sorry?
What related to the time of surgery, what time frame are the scores captured at?
So the pre-procedural were captured. I took them from the procedure database, so I'm assuming the day of the procedure, and then the follow-up was at whatever their initial follow-up was. So we excluded patients with a follow-up past 3 months, so the initial follow-up was anywhere from 3 days to 3 months afterwards. Did I answer your question? Does that make sense?
Yes. Thank
Okay, sorry about that.
How about complications? Was there any difference in the incidence of complications in obesity?
I'm so glad you asked because I actually wrote it down because I knew somebody was going to ask about that. So the VQI defines like 10 different complications at initial follow-up, and I did write them down. I can go through all of them if you want, but the only ones that were significant was the incidence of superficial phlebitis with obese patients, and we found an odds ratio of about 2, so about double chance of having superficial phlebitis. However, complications are still relatively low. I think the numbers were a 0.9% incidence for non-obese patients and 1.7% incidence for obese patients.
Great. Nice job.
Thank you.